Thank you, Brian. And I want to make sure that my technology works and functions a little bit. Oh, wonderful. Excellent. None of what Brian says has given me any opportunity to do the job that I currently hold as the Dean of the Brody School of Medicine. I'm still in a learning mode 6.5 years into the responsibility. And one of the ways that I learn is have conversations such as this with a number of people who are 10 times smarter than myself. First of all, though, I'd like to thank Dr. Dave Herman for the invitation to participate with you this afternoon. And my hope is that at the end of this conversation, we are engaged in creating answers, answers that are useful in our geography, Eastern North Carolina. We're very special here. Many of us have heard stories that cause anxiety, distress, fear for the future. We're not sure. There's ambivalence about where we are going. Medicine is never going to be the same. That has been the mantra. And true, medicine will never be the same if we take all of the opportunities that we face into consideration and put them to the best use for the people that we serve in the region. So I feel excited. And I share this with all of the people that I work with, and certainly with the people that we serve here in Eastern North Carolina. We have tremendous opportunity. Look at that slide. It shows a caterpillar on one side, and the other is a butterfly. There's a piece in the middle, and it's called metamorphosis. There's a thing called a pupal stage. And what happens is that caterpillar eats as much as it possibly can. It generates energy. Then it goes into a protective mode. It almost completely dissolves itself and then comes out as a beautiful monarch butterfly. The only thing that's wrong with this slide is that I should have picked Manduca sexta, which is the tobacco worm. I think it would be more reasonable to have thought about using the tobacco worm for Eastern North Carolina. The only problem with it is that once it goes through the pupal stage, it becomes the Carolina sphinx moth, and that's not a very attractive image. So for today, I'm going to talk a little bit about the good stuff. I want to just put some historical context on the conversation. Then I'm going to talk about where we are, at least in my opinion, and then where we must go. Remember that if Eastern North Carolina were its own state, it would be the unhealthiest of all states. The triple threat is rural, poor, and minority population. Health in Eastern North Carolina is poorer than the rest of the state, and the top 29 counties in our region have the poorest health of all. Many of our citizens live in health professional shortage areas. The elderly population is around 12% North Carolina, which is about the same as North Carolina. Poverty overall is about 16%. North Carolina is 12.3%. The non-white population is 37.6%. So we really are in a special region. Despite that, the perversity of this is to the tremendous advantage of a little medical school that I work for called the Brody School of Medicine. Who would have thought that they would put a medical school in the middle of such perversity 40 years ago? I must say that the people who accepted the responsibility of grounding a medical school in Greenville, North Carolina 40 years ago were either incredibly foolish or incredibly fearless. I'm not sure which one would pertain. I have had a conversation with Ed Monroe. I never had a chance to meet Chancellor Jenkins, but I'd like to say that they were probably incredibly fearless human beings. So the first mission was to educate primary care physicians for North Carolina. You all know that 40 years ago, primary care physicians were in serious problem. They were not able to recruit to the region, and they were barely able to make a living. This is what prompted Dr. Ernest Ferguson to arrive at Chancellor Jenkins' home one Sunday afternoon to impress upon his wife how important it was for the university to create a medical school to provide physicians for the region. Chancellor Jenkins was not home, but he returned the next week to promote his case. And as a result of that, Dr. Jenkins began a campaign which went on for over a decade to have a medical school here in Greenville. The second part of our mission is providing access to careers in medicine for minority and disadvantaged students. And the Brody School of Medicine has done that and has delivered on that promise. Do you remember, can you imagine what it means to recruit disadvantaged students from the public school system in North Carolina? This is now 40 years ago. That was another mission impossible. The literacy rate from our public schools at that time was hovering around 60%. And the call was that we were to select these students and make them into doctors, one of the highest achievements that any human being can have. So again, it reflects on what may have been a foolish plight many years ago. And the third and last is to improve the health status of the citizens of Eastern North Carolina. Well, we're here 40 years later, having a relationship with Vidant Medical Center and Vidant Health, which in many people's minds has been the most successful collaboration over that period of time. And I'd like to give you an idea of what those graphs represent. The yellow graphs represents the performance of the Brody School of Medicine compared to the rest of the nation. Brody sends 21% to rural practice compared to the national average of 7.6%. 35.6% practice in underserved areas, and these are our graduates of the school, compared to 16.1%. 53.7% practice in the same state, and I'm talking about North Carolina, compared to 34.1%. 20.4% are in family medicine, compared to 7.9%. And each of these graphs then indicate that the Brody School of Medicine outstrips the performance of other medical schools across the nation on average. Remember, now this is a number that is continuing to accrue, so this is not a static statistic. 27% of family physicians in North Carolina are graduates of the East Carolina University Brody School of Medicine. One of the things that I must mention is that we're very efficient in doing that. The Brody School of Medicine provides the greatest value medical school in the nation. Our tuition is the lowest tuition for any medical school, allopathic medical school in the continental United States. The total cost the total indebtedness for medical students across the nation on average is about $145,000. For a Brody graduate is $92,500. And this also relates to the type of student that we recruit. The median income for a family that sends a student to the Brody School of Medicine is $80,000, which is below the 10th percentile when compared to other medical schools across the nation. So we're recruiting a really special type of person. All of them are residents of the state of North Carolina, and they come from all communities that represent North Carolina, but more particularly Eastern North Carolina. Here's a picture that I'd like to illustrate for you, and that is Dr. Ken Steinberg, and I'm not sure if there's a, yes, this is Dr. Ken Steinberg, the chair of family medicine, receiving a certificate from the American Academy of Family Physicians, and to his right is the president of the American Academy of Family Physicians, Dr. Reed Blackwelder. To Dr. Blackwelder's right is Dr. Justin Edwards, assistant residency director, and to the far right of this screen is Dr. Chris Dufferin, educational specialist and assistant professor. This is the 8th consecutive year that the Brody School of Medicine has been identified as producing the highest percentage of family physicians in the nation. We're actually number 5 here, but we range between 1 and 5 perennially. So this year we were number 5, but we've been traditionally way up there with number 1. North Dakota seems to take the cake in producing family doctors. The reason is that by the time they're done, they're all frozen and they can't move anywhere else. So we make it easy. How do we do this? We make it easy for students to choose the areas of greatest need. Our students select their professions based on their passions, not for the need to repay their student debt. Student debt can range as high as $300,000 per year easily for a medical graduate in the United States. As I mentioned earlier, ours is somewhere around $92,000. So our students actually can select a specialty, perhaps primary care, without regard to immediately dealing with that mountain of debt. Our students, when surveyed, say that there are only 12.7% of our students who say that paying back the debt is a major priority that motivates them to choose a specialty. So the vast majority of our students actually choose a profession based on the desire to serve the communities within which they will ultimately live. So where are we at this point? The third of the missions of the Brody School of Medicine has been to improve the quality of the citizens of the region in terms of health. And there are 4 bars. The uppermost bar is non-white male. The blue bar is white male. The green is non-white females. And the orange, I think it looks orange from here, is are white females. And this is age-adjusted mortality. And it's a 12-year trend line from about 1979 to 2010, and it's extrapolated through 2020. I like to say that this is really due to the effect of the Brody School of Medicine. No, I'd be totally wrong. It's not just us alone. There are a lot of things that have gone on over this span. But I think we and our health system have had an influence in creating this downward trend in mortality over that period of time. These are really quite stark numbers. The non-white males have seen a 27% improvement in their mortality. The next category, 19%. The next category, 23%. And the white females, a 16% improvement in age-adjusted mortality over that period of time. But I would say that it's a total effect. Better education, better roads, better social programs, better housing, more diverse health capabilities within our region. It's everybody working together, our health department, Veterans Administration Services. The whole spectrum has improved over that period of time. But I'd like to also say that the presence of our medical school had an effect as well. Now, Eastern North Carolina, though, remains poor. It is the continuing triple threat to our future survivability. Poor. Across the 41 counties, 19.6% of the population is below federal poverty in each county. Greater than 50% of counties meet criteria for a federal poverty area, and that is greater than 20% below the federal poverty limit. Rural. The region is entirely made up of rural counties. That's less than 250 people per square mile. And the typical Eastern North Carolina has much less than that, less than 100 people per square mile. Blacks are the largest racial disparity population in the region. African Americans represent 34% of the population of all counties, and the Hispanic population is growing, and in some counties is as much as 12%. I believe in Pitt County it's at that point at this moment. Remember, when I first came to North Carolina in 1981, I moved to Bertie County, which still is approximately 60% African American and is clearly incredibly poor. So, persistent poverty, low access to immediate, high-quality healthcare services, isolation, some who distrust the healthcare system, and this is intergenerational, and places in our region that are hard to reach hamper our outcomes. And we need to take not only objective, make this as part of our objective understanding, but also figure out how this can become an opportunity for us in the future. In terms of children in poverty, 29% of Eastern North Carolina live in poverty. This is children measured under the age of 18. Eastern North Carolina, 29%. North Carolina, 25%. And remember, the healthiest county in the state of North Carolina is Wade County. 15% of the children there live in poverty. We also have a list of chronic diseases that are a plague, including sexually transmitted diseases, HIV, AIDS, syphilis, cancer of the lung, breast, prostate, and colon, injury. Trauma surgeon in me has to put that on the list, but it's true. It's a major concern. Obesity, diabetes, hypertension, coronary artery disease, asthma, chronic obstructive pulmonary disease, and high-risk pregnancies. That's a short list relative to the total compendium of diseases that we would be able to list. But if we were expert at just this list alone, we could actually improve the health and outcomes of Eastern North Carolina. So is this going to be cured overnight? Is this a short list that we can deal with in short order? My sense is that we'll be working this through my career and through the career of others. The work of our school is destined to make a positive difference. This is a long and sometimes arduous journey, but we must not lose faith. I've really given you a reality check then about Eastern North Carolina as it currently exists. And I want to ask a question. Having outlined what I've just said, how does good health interact with high economic viability? Are they separate? Are they the same thing? Are they intimately involved, engaging in some important way? I posit that good health leads to an improved economy, workers who can be productive. It will actually add to our labor market in Eastern North Carolina and play a central role in the future health of the region from an economic point of view. We are special. Here is this is from the North Carolina State Emerging Issues Institute in the Governor Hunt Library. And it shows that even Pitt County, where we are currently sitting, and we're very proud to be here in Pitt County with our magnificent hospital and the very best medical school in Eastern North Carolina. I said that, the very best medical school in Eastern North. Is there another competitor? No. Well, we are 45th. This is 2010 health statistics. We're 45th when compared to the other 100 counties in the state as far as obesity is concerned. 32.2% of our population is obese. I would say that obesity is still a major epidemic. We're making some inroads in terms of our children across the nation. But right now, I'm not talking about the future, right now, this is a major issue for us. And it is an issue for us here in Pitt County. I would say that obesity then, for me, is a surrogate for the overall health of our population. So we have a ways to go in Pitt County. Now let's talk about Bertie County, where I just mentioned. Bertie County, where's Pitt County? Pitt County is here. Bertie County is 99th in the state in terms, at the wrong end of the scale. It's 99th at the bottom. Remember, we have 100 counties, so you can't get much further. And I deny that I have anything to do with Columbus County, which is the 100th in the state. The reason I can deny it is because they're almost in South Carolina. So But all of the sick counties in North Carolina, for all intents and purposes, there are one or few out there out west, but for the most part, we are the sickest component of North Carolina. We are in a nation to itself. So, where must we go? What does this predict? One of the major issues in healthcare is that we are siloed. This is a set of silos in Bethel. We know about silos here in eastern North Carolina. But our whole medical system is siloed. I must tell you, I have 20 departments at the Brody School of Medicine, and they're all siloed. We have silos, unintentional silos between our health department, perhaps, and the medical system. We have a silo between the veterans group of patients and us. And there are other really well-intentioned non-government organizations out there doing good work. And the capacity across our whole region is really quite high. We just are unable to understand what they're doing at the right time to apply the right strategies to help our population at large. So one of the things that we must do is begin to work on those silos, get them working as one. We also have silos inside our university, and we are working hard to break down those silos. We're working, we're one of 11 medical schools in the nation to have received a grant from the American Medical Association. It's called a REACH grant. It's $1 million. But the reason that they selected us is that they think that we have a way of changing the curriculum in which we educate healthcare professionals, not just medical students, in order to create the most effective teams for the future. It's based on new competencies and team-based approaches to care. And so we have the College of Nursing, the most prolific college of nursing in the state, working with us at the medical school, our College of Allied Health, which is very specialized in certain areas and again is the most prestigious in the state. Of course, the innovative new dental school, which is just announced that it's going to open another service learning center in Brunswick County. So it's really stretching across the state. And Dean Chadwick likes to say that he's amputated the top floor of the dental school and is linked electronically across the whole state of North Carolina. He has a virtual educational system that we could all learn from, and we are learning together how to face the future. We have a Center for Health Disparities, which provided some of the data that I just shared, and we have several other departments from across the whole school. Can you imagine the Department of Nutrition helping us to create new strategies to nourish the citizens across the region in a healthy manner? Hospitality management, health and human performance, engineering, biology, just to name a few. So we need to deploy, even within our university, all of our capabilities and apply them to the plight that I shared with you earlier. Of course, we have external partners, Vidant Medical Center, the community health centers, county departments of public health, the North Carolina Office of Rural Health, community and faith-based organizations, don't forget them, local high schools, and community colleges. So in the future, the Brody School of Medicine will be focused on the clinical care and improvement of the primary disease states found in eastern North Carolina. And I listed a short list. If we were experts at that, we will make inroads. The Brody will be focused on physicians, training physicians to stay in rural North Carolina to treat those diseases. And we will continue to attract physicians, retaining them and fairly compensating the very, very best faculty. Our issue is that we compete for faculty on a national scale. It's not just the Greenville economy that we're competing with. We're competing for talent from across the United States. I just had a conversation with the chair this morning where he was lamenting the loss of some young faculty who came here and spent a very short period of time and somehow did not like Greenville and Pitt County. I cannot imagine that. I love it here. This is my home. How could they say that? We have to figure a way of getting people who want to stay in Pitt County and live in eastern North Carolina to stay here with their talent to serve our missions. So the mission remains the same. I came to Eastern Northland as fast as I could. You had already turned earth where the Brody School of Medicine exists. Yes, it was an 8-story building when I came already. I had moved up from a 2-story building to an 8-story building. You'd had probably at the time about 68 medical students coming through the facility when I arrived here in 1984. Now we have 80. We have 80 of the best. So a lot of things have changed, but the mission has not changed. So our form must change. We're going to keep the best, jettison some things that we probably are now traditional, but perhaps not as useful, and apply and focus on the future in a meaningful way. Fewer silos, more and newer partnerships, more and new partners. A focus on disease is no longer efficient and sufficient, i.e. just going disease by disease is no longer sufficient. We recognize the systemic nature of quality of life here in the East, and it goes across a vast range of activities. Thank you very much.